Hello, my name is Lucy. I'm one of the midwives based in the Bournemouth area. I'm going to talk to you today about birthing your baby. Birthing your baby covers the second and third stages of labour. The first stage of labour is the latent phase of labour. This is covered in our first video with Sam and Lucy and refers to the stage of labour where you're usually at home, your labour is not quite established, so your contractions are usually building up, and maybe your waters have broken, maybe they haven't. The next part of labour, the bit that we sometimes call established labour, is the first stage of labour. That's the part where you're usually in your chosen place of delivery, so either you're on the labour ward or you're in a birth centre, or maybe you're at home with the support of a community midwife. The next stage is the second stage of labour, which we are going to cover today. That includes from when you are fully dilated, so the pushing stage of labour, until you have birthed your baby. The next stage of labour, the third stage, is the part where you deliver the placenta and cord, sometimes known as the afterbirth, and this will also be included in this video. So what we're going to talk about today includes positions to have your baby in, different breathing techniques that you can use. We're going to talk to you a bit about your perineum, what it is, where it is, and how you and your midwife between you can protect it. We're also going to talk about your options for the placenta delivery, so the afterbirth, and cord clamping. Before we go on to discuss the second and third stages of labour, I just want to touch on something that we call the transitional stage of labour. The transitional stage of labour generally occurs towards the end of the first stage. So if I had to put a number on it, between sort of 7 and 10 centimetres. It's the stage where you're coming towards the end of established labour and coming towards full dilatation. This is often the stage of labour where women say things like, I can't do it anymore, I need an epidural, I want to go home. And as midwives, we will be there to reassure you. Obviously, if you tell us that you want an epidural at any stage during your pregnancy, we will take you seriously and we will, make plans to arrange that. But often in this stage of labour, we know that actually you can carry on a little bit longer and you'll see the other side. So often you might find that the midwives are actually encouraging you a little bit that you actually, yes, you can do it. You don't need an epidural, you don't need to give up just a bit longer. And what you might be feeling in this stage is you might be feeling a little bit overwhelmed. You might be feeling very tired, very sort of at the end of your tether. And you might also start to be feeling some pressure in your back passage, or some pressure sort of low down. And that's all very normal. All of these feelings are very normal. There's also a massive surge of adrenaline towards the end of your first stage of labour, coming into the second stage, and that's so that you're awake and alert to be able to do the pushing stages where you actually birth your baby. So this also comes into play with the transitional stage of labour and might make you feel a little bit overwhelmed, a little bit different to the way you had been feeling. But rest assured, it's all very normal and your midwife will reassure you of this. So after the transitional stage of labour, you then move on into the second stage of labour. And this is the question that most women ask. How do I know if I'm fully dilated? How do I know if I'm ready to push? Short answer, you'll know. Your body will tell you. Your body will do it for you, some of it. So often when you're ready to push or you're fully dilated, you're going to feel a lot of sensations down below. You're going to feel a lot of pressure in your back passage. And often women are scared of this and they hold back a little bit because maybe they're afraid to pass wind, they're afraid to poo, and all we can say as midwives is please don't worry about it. It's a very normal sign. Actually, often if you do pass a little bit of stools, midwives tend to get a little bit excited because it means your baby is close. And if you think about your anatomy down below, so you've got the 3 key areas. You've got your bladder and your urethra at the top. You've got your your uterus and your vagina, and then you've got your back passage. And whatever comes through your vagina, so a baby's head, is going to press on everything else, particularly on your back passage. Okay, so anything that is there in your back passage will be pushed out of the way by baby's head. And that's also why you're then going to feel a massive urge to go to the toilet. And sometimes, yes, sometimes you do poo in labour, and sometimes actually, whether there's anything there or not, you're still going to feel like you are. So please don't worry about that, okay? Often before labour, and one of the early signs of labour is actually your body already starts to have a bit of a clear out. So actually you might have a bit of an irritable tummy for a couple of days before labour where your body is preparing. So actually you might feel quite empty anyway. So really one of the key signs that you're ready to push is that you've got this rectal pressure or you've got this urge to push. Some people don't necessarily feel that. Sometimes it can be due to your position or because you've had an epidural or any other form of pain relief. So as midwives, there are signs that we look out for as well in you and in baby as well. And that would depend on if we are listening to your baby every 15 minutes or whether you're on the baby's heartbeat monitor. So there are some changes that we can actually look for from that point of view as well. And also, obviously, there is the vaginal examination. So often we will do a vaginal examination to confirm that you are in the second stage of labour. If we suspect it or if you haven't had an examination for a few hours, then we may find out from that. So vaginal examinations, we usually tend to do about 4 hourly in your labour if you consent to it. And that tells us a lot of things, how dilated you are, how close baby is, and what position baby's in. So it is a good tool that we can use to diagnose the second stage of labour. So what happens when you are fully dilated? Well, if you have an epidural or you don't particularly have an urge to push at that stage, we can leave you for up to an hour. Sometimes it's known as a passive second stage. So this stage of labour, we can just leave you until you get that urge, or if you've got an epidural, just leave you to let your body push for you for a little bit and let your baby come down naturally without exhausting you. Then you start pushing, and women often ask, how do I know how to push? How do you push? Again, you're going to have that urge to push. You're just going to need to go with your body and trust your body. It knows what it's doing. Women have been doing this for centuries, otherwise we wouldn't be here. So just go with what feels natural to you. Your body will often do a lot of the work. Once you're actually feeling your contractions, your baby will push down, and that's when you feel that pressure. And that's your body going along with you. So just go with the feelings that you are feeling, okay? And we will talk about breathing techniques as well in the second stage of labour. So how long is it normal to push for? Everybody is different. So if it's your first baby, it's quite normal for it to take 1 to 2 hours to get your baby into your arms after starting pushing, okay? We will be monitoring you very closely during this. We'll be monitoring your baby. So if you are low risk and you've been having your baby listened to with the Doppler, like you do at your antenatal appointments, then we will actually increase that now from 15 minutes to every 5 minutes. So we're going to be keeping a very close eye on your baby's heartbeat. If you're on the monitor, obviously we'll just continue to be watching your baby's heartbeat from that. And if there's any signs that either you or your baby are becoming unwell or distressed at any point, then we will intervene sooner. Okay. We'll move on to talk about different breathing techniques that you can use in this stage. So there are different breathing techniques that you can use in labour. In the second stage of labour, what we need you to do is focus your breathing down below into your genital area. So there's ways that you can practice this before you have your baby, and this can be called either downward breathing or misting the mirror breathing, you may hear it referred to as. It's often a good idea to actually practice this on the toilet. because that's at the point where you feel comfortable and you're going to be able to let go, and that's key in this. So one method of breathing that you can use in this stage of labour, you take a short, sharp inhale. It doesn't matter too much if it's in your nose or with your mouth, and then you're going to do a really long exhale, but you're going to be focusing that breathing and that breath downwards. So actually not a lot of air will come out through your nose or mouth during this. And why they call it misting the mirror, so if you hold your hands up against your face while you're trying this, not a lot of air should actually touch your hand while you're doing it. So have a little practice with me. So if you can hear, I'm making a little bit of a sound as I'm breathing out, and that's how much air should be escaping. Everything, you're just focusing downwards, and it'll make a lot more sense to you once you've had a little practice on the toilet. Or maybe you don't want to practice, you'll be coached through it in your labour, and you will just need to go with your body and you'll know what to do, don't worry.
So we're going to go on now to talk about different positions that you can use in later stages of pregnancy, in labour and during your birth. The first position I'm going to talk about is sitting on the ball. So having a gym ball like this is something you can do at home to actually get your baby into a good position. It's a really comfortable way to sit when you're pregnant. And also, in this day and age, we do tend to sit on the sofa and we do tend to slouch quite a bit. When you're sat on the ball, it really encourages you to have a good curve in your spine. It's impossible to slouch on a ball because you probably will just fall off. You can't cross your legs either, so it really helps to keep your pelvis nice and open and to allow your baby to get into a really good position. When we're slouched on the sofa, our baby tends to gravitate towards your back because his spine and the back of his head is the heaviest part. It generally just tries to rotate. So by keeping a good posture, you're going to let your baby come back round. So that is the ball. We do have them in the hospital settings as well, so you don't need to bring yours in, but it might be a good idea just to have one at home just for the later stages of pregnancy. Another thing that we have is a peanut ball, and this is something you can look into getting as well if you want to. Now the difference with the peanut ball is there's more things you can do with it basically. I'll put it down. If you sit on the peanut ball, as you can see, I'm much lower and my pelvis is much wider. So that means that I've got much more room to get your baby to engage into the pelvis. So it's a really good thing to sit on in your early labour when you want to get that pressure on your cervix, and again for getting baby into a really good position. Other things that you can do with the peanut ball, well, so you can use it on the bed. If you want to have a little bit of a relax, you can actually put it between your legs, because actually when you're lying down, you do want to have your legs slightly open. You can use a cushion, but if you have one of these balls, that will just help to keep your pelvis open while you're lying down. Lying on your side can be a really good position in early labour as well, and for birth. We always say keep upright in gravity, but actually the truth is you can't stay upright your whole labour. It's just going to be too much, especially if it's your first baby and you're having a bit of a longer labour. You're going to need to rest. Sometimes your labour slows down a little bit in the early stages, and that's designed to give you a little bit of a rest. When that happens, it's important not to try and speed things back up again, but listen to your body. This is the break that your body is naturally giving you. So have a little lie down and have a rest. We do talk a lot about lying on your left side. It's important that you're not lying on your back, and it is better to stay on your left, but you can go on your right side as well. It's much more important that you're on one of your sides than lying on your back. So another thing you can do with the peanut ball is actually use it if you're going to be on all fours. Because it's got this curvature here, it's actually ideal to have your bump in, so you can actually lean across it. Or you can put it behind you on the sofa and sit in it for a bit of support as well. So there are plenty of different things that you can do with it. If you're on the labour ward and you have an epidural, you can also use these for your legs, just to keep them nice and open. Sometimes when you've got an epidural, your legs go quite numb and you're not able to really move around the bed. So this is one of the ways you can get into a slightly different position, but still maintaining that nice open pelvis that you would get from being upright and being sat on the ball. So that's the peanut ball. I'm going to move on. If I'm just going to move this ball, I'm going to show you the birthing stool. Okay. So the birthing stool, it kind of mimics being on the toilet. This is a good position to get yourself in at the beginning of the second stage, so at the beginning of your pushing phase when you're fully dilated, especially if your baby is not showing signs of coming down too quickly, and we really need to use gravity to get baby here sooner. So you can sit on the birthing stool, and it just feels a little bit more natural of a position to push in, so a bit like being on the toilet, like I say. You will hear midwives talking about actually pressure in your bottom and feeling like you need to open your bowels. That's what it feels like. So if you can get in a position where you would naturally release like this, then it is going to help you. Downside of the birthing stool is obviously there's a lot of gravity involved. Sometimes this can have an impact when it comes to tearing. So sometimes what we might say is sit on the birthing stool for some of your pushing, and then maybe move into an all fours or lying on your side position for the actual delivery of your baby. Okay, so that's the birthing stool. I'm going to talk to you a little bit more about all fours. So here I have a beanbag for support. You can use the top of the bed, you can put pillows on the sofa, it doesn't matter what it is, but it's good to have something in front of you, just to lean over. And that's a really good position. It really helps to keep your legs wide and your sacral area is on this side. So when you lie on your back, your coccyx in your pelvis, that's your tailbone, is flattened, and actually we know that in labour it needs to actually open up a little bit. That's why your tailbone moves. It's solely for the purposes of labour. So to allow your baby's head to come through, your coccyx usually moves out a little bit. If you're lying down on your back, actually it can't do that because of the pressure. So being on your all fours really helps just to allow that coccyx to open up. Okay? It also allows your back to be exposed so that you can have somebody giving you a bit of a massage, a bit of a back rub while you're having a contraction, if that's what you want. Not everybody does. Okay? So we've talked about the all fours, and we've talked about laying down. There are some positions that you may need to get in for birth that we haven't covered. So sometimes if you're having a forceps delivery or a ventouse delivery, we may ask you to get into something that we call lithotomy. So these are the stirrups. Okay, we only really use this when it's absolutely necessary. So if you're having a forceps or a ventouse, or if you've got an epidural and you've tried pushing in the positions that you can get into and it's not working, then we may use it as a last resort. I can't show you this because I don't have it on this bed. Okay, so that is some of the positions that you can use for labour.
So we're going to go on now to talk about your perineum. If you don't know what your perineum is, then there's a little bit of anatomy lesson for you. Your perineum is the area in between your vagina and your anus. So it's that bit of muscle and skin that you can see between the two. And often when you hear about people tearing, this is where they've actually torn, is the bit between your vagina and your anus, your perineum. And what that is muscle and skin, and it stretches whilst you're giving birth. So when your baby is born, if it's your first baby, often because you haven't had a baby before, everything is quite tight and hasn't stretched before. So baby will be born quite gently and quite slowly, and that's good. That is what we want. I know everybody wants a short labour, but actually at this stage we want baby to gently stretch your perineum so that it doesn't just open far too quickly and cause too bad of a tear. So how can we look after your perineum? So there are things that you can do and things that we can do as midwives to help protect your perineum. It is important to note that actually most people will have some degree of tearing once they've given birth vaginally, especially if it's your first baby. So we're not necessarily trying to prevent you from tearing, but we're trying to minimize the tearing and prevent you from having tearing that is extensive, okay? So how can we protect it? So there is something that you can do when you're pregnant. So from about 32 weeks, you can look into doing perineal massage. And there are many videos online, and there's some information on the Maternity Matters website about how exactly to do this. This is something that you can do yourself with just an oil or some sort of lubricant, and it's a stretching that you can do once a day if you've got the time, or just as often as you can. It's not particularly evidence-based in terms of preventing or minimising tearing, but there are no known side effects or harms that can come from it, so it's worth a try if you've got the time. Some women find it a little bit difficult to reach their perineum, especially at the later stages of pregnancy, so it might be something you ask your partner to do. Okay, so that's perineal massage. Once you're actually in the second stage of labour, it's really important to have that communication with your midwife, okay? She's going to coach you in terms of positions to be in. She's going to talk to you about sort of when to push, when maybe to start breathing instead, and also in terms of hands-on, hands-off, and all of those sorts of things. So we recommend, if you're on land, say, so you're not in the water, that a midwife pops a warm compress on your perineum. So this could be a warm flannel. Or you can hold it on yourself or your partner, it doesn't really matter, but it just aids the stretching of your perineum to have that warm compress. If you're in the water, so if you're in a birthing pool, this will do that as well, okay? So being in a birthing pool will actually help your perineum to stretch, it's one of the benefits. So also what we can look at is what position you're in. So all throughout labour we tell you remain upright and get gravity on your side. Well, actually that is great, and especially in the second stage of labour, if baby's taking a little while to descend through the pelvis, it's really good to have that gravity on board. But when you're actually at the point of giving birth, so when your baby is actually crowning, sometimes it's better to adopt a slightly less gravity heavy position. So maybe lying on your side, maybe leaning forward on your all fours, rather than more of a squatting or a birthing stool position. And that can help to minimise the tearing down below as well. So there are things that you can do, and like I say, things that we can do, but just chat to your midwife at your 36-week appointment and during your labour, and we will do our very best with you to take care of your perineum. So like I mentioned before, it's quite normal for a lot of mummies to have some degree of tearing after they've given birth vaginally. These can be categorised between grade 1 and grade 4. You don't need to know too much about that, that's our job to worry about, but just to briefly mention it in case it comes up. The first degree tear usually just involves the skin, or sometimes grazing, or just small tears. Usually these don't require stitches, but sometimes we may recommend that you have them if we think it's going to let the tear heal better. A secondary tear is the most common type of tear, and a lot of first-time mummies will have one of these, and some mummies who are having their second, third, fourth baby as well. This is involving more of the muscle, and it's quite normal and can usually be stitched by a midwife in the same place that you had your baby. So whether that's in a birth centre or at home, as long as there's enough light and you can get in a good position, the midwife will be able to stitch you there. A 3rd and 4th degree tear will always be sutured by a doctor, and this will always take place in theatre. It's important you have some good pain relief when you're having a 3rd and 4th degree tear stitched, so you usually have a spinal or an epidural. This allows all of your muscles to relax and allows the doctor a lot more dexterity. It'll be much easier for them to actually do the procedure whilst you are numb from the waist down. So we've gone through the 4 stages of tears and the aftercare. There's one more thing to mention, and that is an episiotomy. An episiotomy is a small cut that doctors and midwives may perform to allow your baby to be born either quicker because baby has shown us some signs of distress, or to allow more room for a forceps or a ventouse delivery. This will always be done with your consent and after we've had a discussion with you. It shouldn't hurt because we will always give you local anaesthetic, or if you've had an epidural and it's working quite well, then you should be quite numb in that area anyway. So it shouldn't hurt at the time. An episiotomy is classed differently from a sort of a 1 to 4 tear, but it's the equivalent of a second, so it's only involving your muscle and your skin, and will be stitched either by a midwife or by a doctor in the same location that you gave birth. In terms of caring for your tears afterwards and your perineum, it is very important to keep everything clean and dry down below. Even if you haven't had any tears, you still have a wound inside of you afterwards. So when your placenta is delivered, actually it leaves a wound inside that is covered when the uterus clamps down, but it still leaves an entrance for infection. So whether you've had stitches or not, but particularly if you have, it's very important to keep clean and dry. So that's regular baths and showers, that's changing your pads regularly and making sure that everything is nice and dry, that you're drying off with a towel down below. It's having a shower after you've opened your bowels and making sure everything is clean so there's no chance of infection getting in. It's also monitoring for signs of infection in yourself. So if you're starting to feel unwell, flu-like symptoms, if you've noticed any discharge or any smell down there, you need to get in touch with either your midwife or your GP for some antibiotics and for someone to maybe take a swab as well. So we've talked already about giving birth to your baby, and we've talked about perineums and stitches. So the next thing to move on to is the 3rd stage of labour. And as I mentioned before, this is the stage of labour where you're going to birth your placenta, or afterbirth as you may have heard it called. So what is a placenta? A placenta is an organ usually around about the size of a dinner plate if your baby is a good size and born around about your due date. That's usually how big it is. It's soft, it's sort of like a piece of meat, and what it has is 2 membranes attached to it, and that's the sort of bubble or sac that the baby was inside, and also then has the cord as well attached to it, which obviously will be attached to your baby. So the placenta is right next to your uterus, and your blood supply fills the placenta. It gets filtered, and the nutrients and the oxygen will be taken away from your bloodstream and put into baby's bloodstream. The 2 never mix. And then baby gets the oxygenated blood and the nutrients and everything to them, and then it goes vice versa as well. The waste products go back through the cord into your bloodstream to be excreted from your own system. So that's what a placenta is. Now we just need to worry about how it gets out. A lot of people ask, does it hurt? Well, no. Fortunately, the placenta is quite soft in comparison to giving birth to a baby, so there's no head or bones or anything. So after giving birth to the baby, the placenta itself shouldn't really hurt too much. It may be a little bit uncomfortable as the placenta is coming through, especially if you had some tearing down there. So sometimes it will sting a little bit. And often when you're giving birth to the placenta, you'll have quite a big contraction before the placenta is delivered, and that's to enable the placenta to come off of the uterus and actually be delivered. So you might find some pains in your stomach or your tummy whilst going through the stage of labour, but no, it shouldn't hurt like giving birth to a baby. So what are your options when it comes to delivering the placenta? Well, there are two. So you can either have the option which we call active management. So that's when we as midwives or doctors actively manage this stage of your labour. And that's with an injection, usually in your thigh, or if you've been in the water, often we'll give it in your arm. And this is given quite soon after baby is born, so within a minute of delivering your baby. And this means that the cord will be clamped, usually between 1 and 5 minutes after giving this injection. And then the midwife will deliver the placenta for you. So she'll actually put some traction on the cord, which will still be coming out of you at that stage, and guide the placenta out that way. So you won't necessarily have to do anything except for relax and sort of get into a position that's nice and open so that the placenta has room to deliver. This usually takes between 5 and 30 minutes. Often a little bit quicker with the injection than it would be if you did it without. The next option is what we call a physiological management. So that is not having the injection and delivering the placenta yourself. So often this will take a little bit longer. So usually it will take up to an hour to deliver your placenta in this way. Some people it's quicker than others. It just depends on how quickly your body reacts after you give birth to your baby. After you give birth to your baby and your body knows this, and you start to have changes within your body immediately, and one of those things is quite a big contraction that helps your placenta to come away from the uterus and actually be delivered. And it just depends on your body how quickly that will happen. So it's different for everybody. So that is when the physiological third stage would take place. So how do you make this decision? How do you decide whether to opt for an active or physiological third stage? So there are risks and benefits to both. An active third stage, which is having the injection, is associated with a reduced risk of having a hemorrhage. So actually we found that in ladies who've had the injection, slightly less of them will go on to have a hemorrhage than those who have not had the injection. Having the injection will speed it up, so it will make things quicker. The injection, however, sometimes will make you feel sick. So in some women it will make them feel nauseous, and in some women it might actually make you vomit. We can give you an anti-sickness if this does happen. Sometimes with the injection it can make your blood pressure go up a little bit. So if you already have high blood pressure and have any problems with your blood pressure in the past, what we will do is give you a slightly different injection. So you can still have an actively managed third stage, as we call it, but we'll give you a slightly different injection than we would give most people. If you go for the option of not having the injection, then there's no rush. So we can leave your baby attached to you for much longer. So either until the cord has stopped pulsating and baby has got all the blood, or until your baby is delivered. We can leave baby attached, and it's quite nice sometimes to do that. You can get nice photo of baby with the placenta that's fed them for 9 months. And if you're in the pool, sometimes women opt for this so that they don't have to necessarily rush out of the pool to deliver the placenta. So you can stay in there cuddling your baby in the warm water for a little bit longer until you've adjusted and you're ready to get out. And for some women, they just feel that it's more natural, especially if you've had a kind of a nice normal labour, you haven't had to use much pain relief or take any sort of drugs, anti-sicknesses, anti-hormones or anything like that, then they feel it's the more natural way of going. So it's individual and it's up to you. For some women, it will be recommended that you have an actively managed third stage, and that will usually mean that you have something that makes you slightly higher risk of having a hemorrhage. So this could mean before, when you've had a baby, you've had a hemorrhage. It could mean that you're being induced. So if we are giving you hormones to make your uterus contract while you're in labour, then it would be the expectation that we then give you an hormone to make your uterus contract to have the placenta as well. So some women will be encouraged to have an actively managed third stage, so they will be encouraged to have the injection. So if you're not sure, have a little chat with your midwife at your 36-week appointment. If you're more than 36 weeks, then have a little chat with your midwife at your next appointment. And of course, discuss this with the midwife who's looking after you in your labour, okay? Can you change your mind? Yes, of course you can. So if you decide you want to do it naturally and have the injection, and to not have the injection for your placenta, but actually once it comes to it, you're knackered and you don't really want to wait up to an hour, or you don't want to have to deliver the placenta yourself, then you can just say, and we will revert back and give you the injection. And vice versa, if you are low risk and you haven't been advised that you need to have the injection, if you actually come down to it and you say, well actually I don't really want to get out of the pool, or I don't really want to cut my baby's cord just yet, I'm happy to see how it goes, then just talk to your midwife, okay, and they will not give you the injection straight away. So just to talk to you briefly about the cord and cord clamping. So you may have heard people talk about delayed cord clamping or deferred cord clamping or optimal cord clamping. There's lots of words for it. So what does this mean? So when baby is born, 30% of baby's blood, or up to 30% of baby's blood, is still outside of their body. It's still going through the cord. So what we want to do is not cut the cord straight away. We want that blood to have a chance to get back into your baby's system. We know that there's lots of benefits to this, including preventing anemia later on. And also, whilst leaving your baby attached to you, baby is still receiving oxygen via the cord. So especially if baby's maybe a little bit slow to breathe straight away, we know that the baby is still getting oxygen via the cord. So we don't want to be cutting the cord straight away unless there is a problem, okay? Sometimes if we need to take baby off to have a look, be looked at the resuscitaire, then we may advise having the cord cut earlier, but usually we would wait at least a minute to cut the cord. So if you're having the active third stage, if you're having the injection, we can wait a few minutes after giving that to allow that blood to go through to baby before we clamp and cut the cord. If you've chosen to not have the injection, then we can wait until all of that blood has left the cord and is in your baby's system, or we can wait until your baby's actually delivered to cut the cord. So who cuts the cord? We can cut it if you want us to, that's absolutely fine, but often partners would like to do this little job if they're not too squeamish. So we would generally encourage partners to get involved with that if they want to. Of course, if they don't, that's absolutely fine. Sometimes if you've got another birthing partner, or if you want to do it yourself, then and there, that's absolutely fine as well. I've done that before. So it's something that you can discuss with your midwife at 36 weeks and discuss with your midwife whilst you're in labour as well. So I really hope you found this video useful in terms of delivering your baby and your placenta and what to expect. The next video would be meeting your baby and feeding your baby. So there are next videos to watch if you haven't already that talk about what happens after the delivery of the placenta and after delivery of the baby. We are also running live question and answer sessions, so if you just check out our Facebook page, Paul Maternity, then you'll see those advertised. In the meantime, thank you very much for watching.